Hello everyone. So today we are going to start with our new topic, that is cerebral palsy of pediatrics. So as we know that it is the most common chronic motor disability in the childhood, and its most common causes are also perinatal asphyxia. So starting with it, it refers to the permanent, non-progressive and occasionally evolving disorders of the tone, movement or posture caused by an insult to the developing brain, and it accounts for less than 10% of all the cases. So various causes are also there for the cerebral palsy, such as, first of all, we will see the genetic factors there, such as genetic disorder, inborn errors of the metabolism, structural malformation of nervous system, congenital or intrauterine infections, teratogens, maternal or obstetric complication. Perinatal causes are like birth asphyxia, low birth weight, prematurity, birth trauma, neonatal infection, neonatal hypoglycemia, neonatal seizure, intracranial hemorrhage, neonatal hyperbilirubinemia, and postnatal causes are like infection of the CNS, hypoxia, trauma, drug toxins, and the metabolic disorder. So, what are the clinical features of it? Are like persistence of neonatal reflexes, and also the increased tone, fisting with cortical thumb, scissoring of legs, toe walking, abnormal posture and gait, abnormal movements, or hyperreflexia. So, some common comorbidities also there, like intellect disability, have microcephaly, seizures, behavioral problems, difficulty in speech, language, swallowing or feeding, blindness, deafness, squint, malnutrition, and also sleep disturbances and excessive drooling. Contractures are may also develop. Now, starting with its classification, such as, basically on the basis of the topographically, it is classified in the quadriplegic, hemiplegic, monoplegic. Okay, but physiologically it is divided into spastic, dyskinetic, ataxic, or mixed. So basically, spastic palsy may be quadriplegic, diplegic, or hemiplegic, while dyskinetic may be chorioathetoid or dystonic. So, starting with the spastic quadriplegia, it is the most common cerebral palsy. Okay, and its most common cause is also by perinatal asphyxia or neonatal illness, and the common comorbidity are like intellect disability, seizures, pseudobulbar palsy, microcephaly, squint or visual disturbances, speech abnormality, and the deformity. And the neuroimaging may also show the cystic encephalomalacia and the spastic. In spastic diplegia, it is linked to prematurity, and the neuroimaging shows periventricular leukomalacia. And in this, the intellect is often preserved. Okay, now, but in spastic hemiplegia, they are usually mobile, and they may have preserved or impaired intellect, and its most common cause is the perinatal stroke, and the neuroimaging will be shows like poor encephalic cyst. And another one is dyskinetic or extrapyramidal palsy, such as, which may represent asphyxia or connectors. Okay, rigidity, dystonia, dyskinesia, and drooling are prominent, while intellect is relatively preserved, and radiologically may indicate the abnormalities in the basal ganglia. Okay, and ataxic palsy, it is caused by cerebellar malformation, and mixed means it including both spastic and extrapyramidal features. So as you can see in this table, that all things are summarized here. Okay, following types of cerebral palsy: spastic quadriplegia, diplegia, hemiplegia, extrapyramidal, ataxic, and mixed. Most of the in this, the most common cause is the perinatal asphyxia after the prematurity. Vascular events are also responsible for spastic hemiplegia, connectors, and the cerebral malformation. These are the following clinical features, and its radiological findings are also there. Okay, PVL is found in the spastic diplegia. Okay, that is periventricular leukomalacia. So for the evaluation, physical and neurological examination should include assessment of development and evaluation of dysmorphism and neurocutaneous markers. So spasticity is just classified using tools such as gross motor function classification system and modified Ashworth scale. So starting, let's discuss also its management part. So the management requires multidisciplinary inputs from the pediatrician, occupational therapist, physiotherapist, clinical psychologist, orthopedic surgeon, speech therapist, ophthalmologist, ENT specialist, social worker, special educator. These all needs to be these all person needs to be contributed their all work and all study all knowledge to the forest management. So basically, generalized spasticity, it is managed by physiotherapy and drugs such as diazepam, baclofen, tenazidine or dantrolene. Intrathecal baclofen therapy used as an implantable pump to deliver the muscle relaxant drug baclofen into the CSF, and dystonia is managed by trihexyphenidyl levodopa or botulinum toxin injection, and localized spasticity can be effectively treated with the injection of botulinum A toxin, and some patient may also require tendon release or tendon lengthening, and orthotic devices such as braces, splints, wedges, and special chairs helps to compensate for muscle imbalance and increase independent mobility. So that was all. So thank you everyone.